Our second speaker is Furqan Dadar. He is a newly graduate from Rush University. Congratulations on recently graduating. I'm sure everybody in this room remembers that time whenever they graduated, finished school. He recently completed his rotations at Mercy One Des Moines, Mayo Clinic, and Northwestern. Furqan is also a graduate from Lewis University, where he earned a degree in biology.
Thank you so much for that introduction. First and foremost, I'd like to thank EPIC for giving me the opportunity to speak here today. The topic of my discussion is the TransMedics OCS in cardiac transplantation. I did a meta-analysis on that, so we'll be going and looking into the study I performed. As far as disclosures goes, I have none. So first, we'll start off with an overview of the history of cardiac transplantation. Second, we'll do a review of the TransMedics OCS. And then third, we'll go over my meta-analysis research project. So going into the history of cardiac transplantation, we have 1905, Alexis Carrel and Charles Guthrie, who transplanted the heart of a small dog into the neck of a larger dog. 1959, we have Goldberg et al. Performed an orthotopic heart transplant on a dog. 1964, we have Dr. Hardy performing the first xenotransplant using a chimpanzee heart. 1967, we have the first human donor heart transplant performed by the very famous Dr. Bernard in Cape Town, South Africa. And very recently, in 2022, we have the first xenotransplant performed with a genetically modified pig heart at the University of Maryland. So kind of going into what is the OCS. The OCS is a portable warm perfusion and monitoring system designed to keep a donor heart at human-like metabolic active state throughout the whole entire period of transport. So some key things that you can monitor while the heart is on the OCS, you can look at your aortic root pressure, your coronary flow rate, your hematocrit, oxygen saturation, temperature, and you can also administer medications such as low-dose epi and adenosine while it's on the OCS. I did read a couple studies where they did a coronary angiograph actually using the OCS for a heart that they were considering to use. So they actually did a coronary angiography by inserting a 6 French sheath into the access port, and then they injected dye into the respective ostia, and they got X-ray imaging from the cardiac catheterization lab. So the main advantages of using the OCS, you have the ability to assess heart function, which is the primary one. And as that study showed, you can also do a coronary angiography of a heart that you're considering to use or not to use. The main benefit is you can have an extended ex vivo time compared to the 4 hours limitation that we have with cold storage. You can prolong that. You can also transport these donor hearts for a very, very large geographical radius from your base institution. And by doing so, you're expanding the donor pool. As we know that there's a huge need for organs for transplantation. So this just helps foster as a solution to that problem that we have. The primary limitations with the OCS usage, the first one being the cost of the equipment. I remember a speaker earlier this conference said that every circuit's around like $80,000, so it comes with a hefty price tag, and it requires specially trained personnel. So jumping into my research project, the purpose of my study was to review literature and to determine whether a difference exists in short-term outcomes within heart transplant patients who were implanted with hearts preserved with either the OCS or cold storage technique. So my research question was, what is the difference in 30-day mortality among heart transplant patients who were implanted with hearts preserved with the OCS compared to patients that were transplanted with hearts preserved with cold storage? The primary objective was to find that 30-day mortality difference between the OCS and the cold storage. Our secondary research objective was to find which preservation method required a higher need for inotropic support and mechanical circulatory support post-bypass. Operational definitions for my study, 30-day mortality, seeing if the patient is dead or alive 30 days post-transplant. Cold storage preservation with the hearts being arrested with cold cardioplasia and explanted for the donor and placed on ice for the entirety of transport till the point of implantation. And the TransMedics OCS using low-dose cardioplegia, hooking it up to the TransMedics OCS and establishing normothermic perfusion of the explanted heart till the point that it's surgically implanted into the recipient. So primary research design was a meta-analysis. The three main databases which I pulled my articles from were PubMed, Scopus, and Embase, and that was my lovely search string. For my inclusion criteria, studies that included patients that underwent cardiac transplantation, cohort studies, cross-sectional studies, non-randomized control trials, and randomized control trials, articles published after the year of 2000, and articles that reported third-day mortality in cold storage and the OCS. Our exclusion criteria was studies that use pediatric patients less than the age of 18 years old, ex vivo greater than 6 hours, case studies, editorial and opinions, duplicate articles, and any articles that were published in language other than English. So this here is just the basic brief diagram of how I perform my article screening. First, just doing a rough search, getting those articles, doing a quality evaluation on those articles, doing data extraction, and then finally making a forest plot out of the data that we extracted from those articles. This is just the same thing, saying that we perform the article search, ensure that they followed the inclusion criteria that we set for this study, and we did a quality evaluation using Prisma, and we did a data extraction. This is my data extraction table, looking at database, first author, country of origin, abstract summary, study design, number of subjects, obviously 30-year mortality, total ischemic time, use of inotropes, and the results summary of that article. This was the Prisma checklist that we utilized to evaluate the quality of our studies. So for the data analysis part for a meta-analysis, was the primary points were to generate a forest plot and to calculate an effect size. So this is my 30-day mortality forest plot. We found that there was a statistically significant outcome in 30-day mortality with a p-value of 0.02. Overall risk difference and overall effect size between the two preservations group yielded to negative 0.04. Measurements of heterogeneity within the study were evaluated via tau squared, which yielded a value of 0.0, and an I-squared value, which was 55.53%. So kind of going back to the heterogeneity measurements, the tau squared test having yielded a value of 0.0 highlighted the absence of random heterogeneity and random error between the studies that we included in our meta-analysis. The high level heterogeneity that was highlighted by the I-squared value, we attributed that to using studies that were from across multiple institutions across the globe. So each respective study used a patient population which differed and varied from each other. This is my forest plot for my mechanical circulatory support post-transplant. We found that a reduced risk of mechanical circulatory support with hearts preserved with the TransMedics OCS, negative 0.05, but this reduced risk was found to be not statistically significant with a p-value of 0.43. The measurements of heterogeneity within the studies were evaluated to chi-squared with the value of 0.02, and the I-squared value for this forest plot was 82.27. So this forest plot did demonstrate a low level of random heterogeneity between the 7 studies that were included for the mechanical circulatory support. The I-squared value being 82.27 was pretty high within these 7 studies, and we just attributed this to the different methodologies that each study implemented. This is the cold ischemic time forest plot. So the main thing here, the OCS group is associated with a 103.68 minute decrease in cold ischemic time. And this kind of goes back to the fundamentals of how these preservation systems function. With the OCS, your real ischemic time is just how long it takes for the surgeon to cross-clamp and put that heart onto the device versus cold ischemic time. That's from the moment you cross-clamp the heart in your donor all the way until your cross-clamp is removed in your recipient. So the strengths of this study, we utilized multi-center data to answer the research question, inclusion of high-quality articles, and ability to include and analyze a significant amount of heart transplant patient data, and we did a specific focused analysis upon short-term outcomes of these patients. Limitations that we didn't look at the long-term effects of each respective storage and the effects that it has on functional graft performance. We were actually not able to analyze inotropic support just due to the fact that some studies report it in many different ways. Some studies would report it as specific concentration of drips, versus others would just say it was high and not define that category, what is high, what is low. And some studies would just report the days that they were on inotropic support. So we decided not to go ahead with that analysis as there was not uniform data reported. And the main limitation within the study was the degree of heterogeneity found between the articles that we used for this study. So in conclusion, this meta-analysis found the OCS to yield a statistically significant lowered risk of 30-day mortality when compared to cold storage preservation. There was no statistical significant difference found between the OCS and cold storage in terms of mechanical circuit support required post-transplantation. Future research is needed in analyzing inotropic support and the long-term effects between cardiac graft preservation methods. Before I end, I'd like to give a special thanks to Julie Collins, Alison Weinberg, and Gurinder Gill, and my research partner, Richard Farley, for helping me throughout this whole entire process and conducting the study. These are my lovely references, and thank you so much for your time and your attention.
Go ahead. I was going to open for questions, and I was going to start with one actually, to be honest. So, in your analysis, you had exclusion criteria, which was anything over 6 hours that you were going to exclude. Why did you pick that number?
We picked that number, so the recommendation from TransMedics is around 6 hours. So we wanted to follow within that guideline, so we didn't want to include any procedures that exceeded that recommendation time and kind of skew our data with having just high run times compared to the normal run times that people usually have on the OCS.
I'm going to ask another question, and this is going to be unfair, and it's not going to count towards it, but I just wondered if you knew. When you're doing a meta-analysis, there are subtypes of kind of how you do it. Do you know what type of sort of either fixed effects or random effects model that was built into it?
I think it was a random fixed.
Good. Any more questions?
Just a few remarks. Because this is like kind of a competition, so I'm just going to give you some tips on presenting. I gave a very bad presentation this morning, so ignore that. But just like I'm just going over some criteria. So like, don't read too much from your slides, because that's typical beginners thing. And use your time. You finished in 10 minutes, but you have 15 minutes. I know you want some questions. And then when you did your analysis, so you found that the cold ischemic time was, of course, way longer in the cold ischemic group.
Yeah.
Would you, when you saw that, were you like, okay, maybe I shouldn't have considered this as an outcome measure?
We just wanted to compare all the data from the articles that we chose. So obviously we knew that was going to be the result, but we just wanted to put a data, like a graphical representation of that.
Okay. And then just one more tip, like you showed some pictures, like the Prisma checklist.
Mm-hmm.
Like we saw it for like 0.2 seconds. So it's, and you cannot even see what's on it. So it's kind of redundant, but don't take it personal. It's just
no worries.
For in the future for
better
sure. Presentations. Thank you.
Yeah.
Good job, by the way.
Hey, Furqan, I want to let you know that I congratulate you for your graduation here.
Thank you.
I have a absolutely different opinion of your presentation than what he gave you. I thought you did an excellent job. I'm a horrible presenter too, but you just learn from doing it with experience, and I appreciate you doing it. And I know you guys are all nervous as all get out, but I think you're doing a wonderful job. I'm just kidding. He has some good suggestions, but anyway, congratulations on your graduation. But I didn't know, did you give your, how long your longest OCS run was?
I believe there was an article in 2019. They did an OCS run for 12 hours.
12 hours. Okay.
Yeah.
Very good. Thank you.
Yeah.
One more question.
You may or may not know the answer to this, but with this system, what errors have been seen? Like so you said it's an $80,000 system, right?
Mm-hmm.
So what could potentially go wrong, right? Because if you're just using a cooler and ice and solution,
Correct. A lot more simpler.
it's a lot simpler. And from what I'm understanding, you're only getting an extra 2 hours, right?
But with the
So-
recommended time that
Recommended
TransMedics-
time.
yeah.
But did you guys find out anything like that could possibly go wrong with this system? Has that happened, or do you possibly know?
That wasn't really the primary focus of the meta-analysis, and as a student, I never ran the OCS myself. I've only been in transplants where the heart came on the OCS and we were just implanted into the patient, and I would pump that case. So I haven't actually utilized the OCS during the period of transport.
Okay.
All right. As far as things going wrong, at my former hospital, the perfusion team actually ran the TransMedics. We went out on the runs and we would bring them back. Recently, the machine didn't turn on. Luckily, it wasn't our team, but the machine didn't turn on and we lost the heart. So things do go wrong. It's an electronic, it's a component, and it goes wrong. And you're often life flighting, so you don't have an option to carry a backup. It's a big box that probably weighs close to 100 pounds. So there's no opportunity to carry a secondary box. So when the machine didn't turn on, they lost the heart. There was no way to preserve it. The second part of this is I wanted to ask you, you were comparing cold storage, which is brain death, but I'm assuming that TransMedics were all DCDs.
DCD, and some of the studies also use DBD as well.
Okay, so as far as your mechanical support, did you include ECMO with that? Because they often need ECMO post and not necessarily a VAD, but they do often need ECMO.
Yeah, that was ECMO is what we compared with mechanical surgery support.
Okay.
Yeah.
Also, as far as TransMedics, I was stuck in Texas in 2019 for 32 hours with a long DCD TransMedics. So there's a staffing component to it, and then there's an electronic component to it. So just.
Is it the same solution that you use when you go and get a regular heart? Is that what's going on? Like, I'm trying to understand. So.
We use Del Nido. So for DCD hearts, the patient, the donor, has to pass away. And that is our warm ischemic time. So when the patient passes away, you then have to wait oftentimes about five minutes. And then it's a rush to the donor. It's an incision. You then have to pull off 12 to 1,500 cc's of the donor's blood. And that's what you use to prime the machine. So that takes an additional minute to 2 minutes. And then they cross clamp and they flush with the Del Nido solution. And that's when your cold ischemic time starts. Then that is your first cold ischemic time. Then, yeah. So then from there, it goes on.
Thank you.